Hi guys, good morning. I hope everybody can hear me. Welcome to this morning's webinar, or this afternoon's webinar. I'm losing a sense of time, obviously, over the last 7 days. This is the first in a series of webinars, and I know Magda will have sent you out a timetable of events for the next few weeks to help, I suppose, break a little bit of this boredom. Starting with session 1, and probably the most important for us at the moment, which is managing endodontic emergencies in the current climate. We'll then move kind of through essentially the whole discipline of endo over these next few weeks. And I'm happy, obviously, to change any of this if you guys wish. But we'll do restorability and prognosis and how to make our decisions, and then right through access, instrumentation, obturation, and maybe a little bit on root canal retreatment to take us into May, by which time, hopefully, we will be moving back to a sense of normality and hopefully getting close to returning to practice. This is webinar format, so I hope you can all hear me in terms of a sound check. I think it's important as well that if you can hear me, that you just let me know on the chat, and if you can't hear me, obviously I can try to make some adjustments for us. There's also a Q&A function as well. I'm having some additional help here. My little 2-year-old has just come into the room. There's a Q&A function, so feel free to ask me any questions you want to as we go through this. If you can keep them kind of relevant to the slide that's on it, that's important, because obviously I'll see these flash up on the side, but equally we'll have plenty of time afterwards to talk through stuff if we need to. All good resound, which is good. Thank you very much. And also, we have plenty of time over these next few weeks. So I think we can do case-based discussion sessions. If you let me know through Magda or even through the Q&A, then I'm happy to arrange those, put up some images, and we can talk through them. And the only other thing I will say is it's a strange time, I think, and day that I picked. I'm normally in practice on a Tuesday. So I picked 12 o'clock on a Tuesday because it seemed to be the logical thing to do, because I'm doing university and NHS stuff on a lot of the other days. But equally, for some people, if this isn't convenient and you wanted to change it to an evening, or, you know, even a weekend morning, whatever, just let me know. And again, I'm happy to make any changes that we need to. So the aims for today, and I think probably the best place to start here would be to consider what is an emergency. And I love a Google definition, and I'm going to show you what an emergency is in a second. But we'll also talk throughout today about the new approach essentially to how we manage our patients. And we'll talk about some strategies for their management, where we get our guidelines. And it's strange, you know, over the last 7 days, I think I've looked at about 100 different documents in relation to emergency management of patients, particularly in endo. And this has changed and continues to change all of the time. You will be aware, or you may not be aware, of some of the emergency services that have been set up. And I will talk through those as well. They are changing slightly from time to time, but I think most places around the UK are set up pretty well in relation to this now. I don't really know what just happened over the last 7 days. It's strange. I left to go on holiday on the 6th of March and everything was completely normal, and went back to work on the 16th of March and everything was changing pretty rapidly. And I swear I had never ever understood or really thought about what an AGP was. And that's all anybody was talking about. I now know what an AGP is, and I know that they're bad in relation to this current virus. And I also know that our role in dentistry, based on what I've listened to over the last few weeks, is to try and minimize our impact on the overall progression of this disease and to try and return to normality as quickly as possible. And I think that's probably our goal to begin with. A lot of it is related to the availability of PPE. I'm sure that will become more available as we know more and learn more and manage more in relation to the problems we're facing. But I think it's important now that we don't create too much by way of a problem. On a positive note, I noticed that the GDC also talk about the idea that it would be good to do remote CPD. So I saw that as, I suppose, an opportunity for me to do something, because it is very, very different, obviously, to being at work. And it gives us a chance as well to go through this CPD. And now, you know, there's never really a better time. It's very cliched to say every cloud has a silver lining, but equally, we find it hard sometimes to attend courses. The motivation isn't there sometimes for us. We've got limited time. And now that we can't work clinically, I think it's a great time to do a little bit of CPD and do it in a kind of a block of CPD as well, so that we can turn around and we can say at the end, well, look, at least I've learned something in relation to this at this point. In terms of today's webinar, what is an emergency? You can see here, as I said, I love a definition from Google. It's a serious, unexpected, and often dangerous situation requiring immediate action. And I think although the SDCEP document that was released today talks about different, I suppose, senses of urgency within dealing with emergencies in the dental setting, if we look at a situation like this, a lot of it will require immediate action. It's just that the action won't be physical action to manage the emergency itself. And I think part of today's webinar will talk about how we approach these situations and how different it's going to be for us in comparison to what it was before. When we look at our definitions of emergencies within the endodontic setting, and really a lot of these are the problems we're going to face, and you can see the list that I've put up on the screen here, and I've included oral cancer, not because that's particularly related to endo, but primarily because it's sometimes, from a patient's point of view, will manifest as an ulcer or a swelling, and their immediate concern may be a worry about something being present that could be sinister within the oral cavity. And a lot of our role in that situation is to go through an algorithm, and I've really used that word a lot over the last 7 days, but go through an algorithm in your own head and reach your own diagnostic conclusion so that you can give the patient sometimes just reassurance. Someone has asked in relation to the previous slide, using suction or aspiration, does that constitute an AGP? And you know, it's interesting because I have a lot of friends, I'm Irish, obviously, a lot of friends who are still working in practice in Ireland, albeit at an emergency level, and some friends in Australia where I worked as well, and they were slightly behind us in terms of how we adopted, I suppose, our current system. And I know in London as well, there was talk of using 2 different aspirators and saliva ejectors and rubber dam. And ultimately, I think the response to the question is, yeah, it's still an aerosol generating procedure. And I think at present, because of the lack of availability of PPE and I suppose the confusion in terms of what kind of an impact the disease could have on a dentist and what kind of an impact dentistry could have on the spread of the disease, I think we're including everything as an AGP. But I have to say, and it's just a personal opinion, I think over time that may possibly change. And we will, of course, develop systems and protocols in order to minimize it and reduce risks of cross-infection going both ways. The SDCEP released a document I think it's either yesterday or today, but I received it early this morning. And it's a really good document. And a lot of their stuff, to be fair, is very, very good. And you can see on the screen, they're talking about the principles that we need to apply in terms of our management of patients at this point. Everybody knows probably about the 3A's approach, our advice, analgesia, and antimicrobials. And I think there's some other important stuff to take out of this as well. If we look here and if we see that you can see, for example, that you need to prioritize the most urgent care needs, which we will be very used to, and you guys, especially in general practice, will be used to doing. And adopting those principles and keeping your principles is very, very important. And I think really importantly as well, if you look 48 to 72 hours should elapse before you're kind of revisiting this. And that may or may not be practical. I think one thing that we will have an advantage with is that there's a really good general dental population within Edinburgh. We've got lots of really good practices. You guys know your patients, and you will be able to identify the nuances within the discussions and the consultations you will do with your patients, even from a remote setting. And I think that's really, really important. You know, some patients aren't going to wait 72 hours to be called back. And some patients, albeit they may only be seeking reassurance, it may be much better to give them reassurance within a 24-hour period rather than waiting for 72 hours. I think as well, the SDCEP have correctly talked about emergency care and urgent care and different ways, I think, of considering this. You can see they're talking about bleeding here as well. That's not particularly relevant to endodontics, but if we look at what the patients are, or what the SDCEP are recommending here, really a lot of the, I suppose, advice and self-help can be offered initially. But then we're moving on to things that are a bit more severe. So things that, for example, are not being controlled by analgesia or antimicrobials or even just advice. And then equally, you've got your really urgent situations that I'll talk about as well later. Thankfully, urgent situations should be relatively limited in dentistry. I know there will be severe trauma. I know there will be some situations where patients are experiencing bleeding, but because of the lag in relation to treatment not being done, often those situations may not arise unless the patient has got an extremely pronounced infection or unless they've suffered a severe trauma. So I think that, I suppose, is one thing that's going to give us some kind of respite in terms of dealing with these situations. So phone consultations, do they actually work? I looked into this a lot because I know I'm going to be answering the phone a lot over the next few weeks, and that's something I never like doing. I suppose it depends on how you look at it. What's your outcome measure? Does a phone consultation work? Well, yeah, there's a contact with the patient. Do you and your patient get out of it what you need? That part I'm unsure. Lots of studies talk about whether or not if you do a phone consultation, you avoid admission to hospital, and these are often done in a medical setting. And yeah, I suppose that is relevant to us, because if you can give advice or if you can prescribe antimicrobials or analgesics, and if the patient doesn't need to go to a green or a red center in NHS Lothian, yeah, obviously that's a good thing from everybody's point of view. I think it's important as well to consider whether or not the patient is getting anything out of these consultations. And interestingly, this was a randomized control trial that was done in relation to phone consultations. And they talked about the idea of, obviously, was it associated with time saving? Which, yeah, it was. Although interestingly, a lot of these phone conversations, when I looked at the papers, they've got an average time of about maybe 5 to 8 minutes, which, if you think about it in a face-to-face contact, it's pretty low. But if you think about it in terms of phone conversation, it's longer, you know. So it's quite a long time to be on the phone talking through something with somebody. So keep that in mind. But equally, they looked at PEI scores in this particular study, and that was essentially patient perception of what had gone on. And it didn't result in lower scores. And again, that's kind of to go back to the fact that you will be familiar with a lot of the people you're talking to. And I think that's important, is to tailor the advice, and more importantly, tailor the approach for each patient in a very kind of an individual way, because it isn't just about information gathering. You know, there's a lot of things. And when you look at this paper, they talk about emotional intelligence and your clinical interview performance. And interestingly, in this paper, they found that in male and female dental students, that at the first interview, female students outperformed males. in terms of how the patients felt the consultation had gone. And when we're not treating patients, often that is going to form a large part of the patient perception and a large part of the advice section from the SDCEP and from all the other organizations that have adopted this 3A's approach. Because if a patient feels as though they're getting good advice, feels as though they're being listened to, feels as though the tone of the conversation is something that they think is acceptable or reassuring to them, then obviously the outcome from their point of view will be good as well. I think what's important as well is that we actually listen to what they're saying. I've quoted this paper multiple times in lectures that I've done down through the years, and it essentially talks about the average amount of time. Now, a lot of these are medical, to be fair, but I have to say, I don't think dentists, certainly me, are any better than doctors at listening. And when you look at the average amount of time before a medical resident interrupts a patient, you've got 12 seconds after they got into the room to talk to the patient. So 12 seconds is not a long period of time. It's very, very, very important that patients feel as though they're being heard in situations like this. I personally am not an enormous fan of too many interruptions in the first instance. You want to give the patient the opportunity to tell you what's going on, because often I will ask a patient, and now this is a physical examination, but I will often ask, which tooth do you think it's coming from if I'm having difficulty in diagnosing a pain case? And, you know, some people don't believe in that. Some people will say, well, you know, if it's an irreversible pulpitis, it's poorly localized. Sometimes they can't tell you even the correct quadrant, let alone the tooth. But a lot of times, and this is anecdotal, yeah, they can. Now, again, it's to go back to the idea that we're not going to be doing a clinical examination. And so sometimes you do need to interrupt a patient, because what is important to you is what's relevant. And again, back to the Google definition, it's closely connected or appropriate to what is being done or considered. Interestingly, we diagnose in different ways. So there is one approach where if we were robots, or it was artificial intelligence, we would listen to the patient tell us every single thing. We would wait until we accumulated all of that information, and then we would compute out the answer. But as practitioners and clinicians and people who have done this for varying periods of time, you find yourself, when a patient speaks to you, immediately starting to diagnose. So if a patient says to you, you know, I was a patient of yours, you put a filling in 6 weeks previously, and you're thinking, hang on a second, and you told me the filling was deep and that the tooth would be sensitive, and you're thinking, hang on, this is going towards a pulpitis, and now it is very sensitive, and it's very sensitive to cold and sometimes hot, and it's starting to keep me awake at night and be a little bit tender when I'm biting. Really, you have kind of reached your diagnosis far before the patient has given you all that information. And so you don't need all of the information in order for you to actually come up with an answer. So bear that in mind, but equally sprinkle a handful of salt on top, and remember in the back of your mind, residents interrupt patients after 12 seconds. Our new practice is going to be conducted over the phone. And so in the same way as I'm sure you want to do a great job when you do a piece of clinical work, we're going to have to try and do a great job when we're carrying out a phone call now, because that is our practice for the foreseeable future. So that's really, really important to keep in mind. And remember, please remember, we are not going to carry out a clinical exam. So you don't have that safety net anymore, because often I find when I am in a rush, or when I am listening to a patient talking about the sick parrot that I had up on the previous screen, I find myself going, it doesn't matter. I don't need all this information because I'll have a look clinically anyway. And we don't have that luxury on these occasions. So there's no question. And again, without being cliched, every cloud and all that, but there's no question, we are going to get better at history taking. We are going to get better at reaching diagnoses based on what a patient is telling us. We're going to get better at taking pain histories. We're going to get better at listening to our patients' descriptions of pain. And I think, again, that's going to be something that we should be able to utilize when we go back into clinical practice. And hopefully, now we don't know this, and this I suppose is certainly a generalization, but hopefully that should improve our diagnostic ability when we go back and we start treating patients again. So if we look at infection, because infection for me is probably the main worry. Someone kind of tongue in cheek said to me, as I said, I looked at a lot of documents over the last few weeks, but someone said, you know, An irreversible pulpitis isn't life-threatening. Now, it wouldn't be my first line of approach if a patient contacted me in severe pain with a toothache, but ultimately, you know, if we're blunt about it, that is the case. Of course, there's an enormous impact on quality of life. And of course, there's going to be a patient who's extremely frustrated, but infection is your main worry. And I like the way over the last week or so, we've adopted a lot of kind of little acronyms and lots of little kind of simplistic approaches to managing situations and conversations and administering advice. And we've got the 3 A's, and we've got Ken Hargreaves, which I'll talk about later, talks about the 3 D's in relation to management of pain or infection. And for me, I saw a lot about infection and when I might worry about it. And I think the 3 S's probably is a good way to think about it. So where's the site and why is the site important? And, you know, as much as I have tried to learn over the last few days, these fascial spaces and where infection spreads to, I can't do it without a diagram. So I'll show you that on the next page. I find that really hard to do, and I've always found it confusing. But we know lower molars, they're a risk, 7s and 8s. We know that upper canines are a risk. So the site of it is important. The size is important as well. I think that if a patient says to you, look, I've got a little swelling, it's adjacent to a tooth, it's in my mouth, as opposed to a patient saying to you, yeah, I mean, my face is completely swollen. And, you know, one of the advantages we have, and I'll talk about the practicalities of doing these consultations later, and I suppose the IT stuff that's important. But if we look at patients talking about swellings, a lot of this can be done on FaceTime, you know, or a patient can send you a photograph, and that's the new world that we're going to be living in, you know, whereas before I would never had a conversation with a patient over FaceTime. And I would have blocked my number, and I would have done numerous different things, you know, to try and keep it, I suppose, in a weird way, professional in inverted commas. But we will adapt to that. And I think, you know, if a patient has a swelling and you want to see it, then you would like them to potentially send you a photograph or to see it on FaceTime. And finally, the final S is the patient systemically unwell? And again, this was something I always found really unhelpful when I trained and when I worked as a dentist, because I would say, you know, I would say to the patient, do you feel unwell? And they would say, no, I don't feel unwell. I mean, how do you know if you feel unwell? I think what we're looking at here is there a sign of spreading infection? That's the most important S. And lots of people are going to be checking their temperatures for a variety of reasons over the next few weeks. So if a patient has a thermometer, you know, ask them, you know, do you feel clammy? Have you taken your temperature? You know, do you feel well in yourself? Don't just say to them and ask them too many open-ended questions, because I know history taking, a lot of people are very much in favor of just open-ended stuff, but you've got to help a patient as well. You can't say to a patient, how severe is the pain? I mean, how do they grade that? Mild, moderate, severe, 0 to 100. So help them in relation to that and give them, I suppose, ways in which they can communicate the correct information to you without putting words in their mouth. Okay. And equally, we look at these images, and these are the important things. So where is this infection going to go? Where is an infection going to go associated with a mandibular second molar? What are you worried about if it spreads there? Are you worried if the patient is going to end up with, you know, a little swelling intraorally, a sinus? No. You're worried about spreading infection. So you're saying to that patient, do you have a temperature? What does your mouth feel like? Can you swallow properly? Can you breathe properly? If it's spreading up to the eye, can you see properly? Does it look normal out of both eyes? Is your vision limited in any way? Look in the mirror and tell me whether both of your eyes look similar. Is it sore under your jaw? In a way, you're almost going to be teaching the patient how to do the dental examination so they can communicate the information to you. And that's something I'm going to repeat later, actually, in relation to management of teeth that may potentially have pulpitis. It's interesting because I said tongue in cheek, one of the things that scares me about all this stuff that's happening is I hope patients don't realize at the end of this, wow, I didn't even need my dentist. All I need to do is be able to, you know, check myself, and then I'll get a prescription, or I'll have it managed in a kind of a distant way, which of course I'm saying as a joke, but you know, it's interesting. That is the kind of philosophy and the approach we're going to adopt now over the next few weeks. And I think this is really good from the SD-CEP, because this talks about, you know, infection specifically related to an acute apical abscess, but this can be applied, and this algorithm looks to be similar for every type of infection, even if it's a pericornitis, for example. But you give them advice and self-help. If a patient's in pain, tell them about analgesia. We, all of us, me included, we have always been overly reliant on antibiotics. I think both in a personal way and also in a professional way. So that's something we probably will need to scale back. And I read a thing recently that described antibiotics as something we should look at as a non-renewable resource, essentially, because of the resistance that's developing. And the number of people who die annually from diseases related to antibiotic resistance, it's huge. So do look at them as something that you think, this is a safety net that I have, and it's something I'm going to use, but equally treat them carefully. But you can see the advice in self-help spreads down to urgent care. So is the patient, do they have spreading infection without airway compromise? Because if they've got that, you're thinking, well, hang on, antibiotics should be able to manage this. Before finally you're saying, okay, this patient is describing an emergency, a true emergency to me here, where I think they have spreading infection that is likely to result in airway compromise and is likely to cause serious problems for that patient. And I think, you know, in a strange way, I think initially we will probably find ourselves maybe thinking that more often than it's actually happening. And that's fine, because I would rather have it that way around than the other way around, where you're thinking, nah, I'm sure it'll be fine, and then it's not going to be fine. So I think that's something to keep in mind as we go forward. And so that's infection. Trauma is a funny one, because every document I've received over the last few weeks has talked about avulsion being a serious emergency trauma situation. And that's funny, because actually an avulsion, if you have got a tooth that's avulsed, okay, yeah, it's time sensitive. We all know about 60 minutes extraovular dry time. We're going to store the tooth in milk, and we're going to tell the patient, if possible, give it a clean, stick it back into your mouth. But what I find interesting is that an avulsed tooth, even if it's been out of the mouth for a short period, the incidence of replacement resorption is quite high. Replacement resorption in terms of a longer medium-term outcome to trauma is not catastrophic, because it's bone that's replacing tooth. And so actually the site you end up with later is not so bad. It's not an infective risk often, although the tooth may need to be accessed, and that might need referral on to one of the Lothian emergency services. But there are other injuries to consider as well. And one of the important things about trauma is that there are multiple injuries to consider. And if you look at this famous Donald Rumsfeld quote where he was talking about known knowns and known unknowns, that's one of the weird things about trauma, because it's very hard, and especially in a phone interview, to say to a patient, what happened? Well, I fell over. And you know, tell me about it. What do your teeth look like? And if you look at the dental trauma guide, and this really, really is a very good resource. And I have told this story loads of times before, and some of you will have heard this at various lectures that I've done. But I remember when we started the trauma clinic in the EDI, I would always have loads of units, because there was this perception that we were going to be inundated with trauma. And there were mornings when it was busy and other mornings when it wasn't as busy. But I would always have multiple computers that I was logged into, and people would say, you know, he does that because it's so busy. And really I would do that because I would want dental trauma guide open in an alternate unit, because the patient would come in, and sometimes I would think, God, how long do I spend that for again? Or what do I say? And I'd pop in and I would check dental trauma guide in a very kind of a guilty fashion for the first few months, until I realized that everybody around the world was doing that, because it is a resource for the management of trauma, and it is designed by experts in dental trauma. So for me, I might consider gaining access to this. It's $30 for an individual membership. I don't know whether they're offering any kind of reductions based on this virus outbreak, but it's something I would definitely look at. Or maybe I know some practices in terms of your emergency service are kind of grouping together. So it might be worth, and to be honest, this is what a lot of people do, get one login, $30, and disseminate the login details. You know, you don't quote me on it, even though I'm doing this in a webinar, but you know, it's a really, really valuable resource. So if you've got a patient, and thankfully, yeah, thank you, Fiona just said Dental Trauma UK include access to their membership as well. So if you're a member of that, they will give you access. And I think it's handy to have some kind of pro forma to say to a patient, where did it happen? How did it occur? But also to have the things in relation to why you're asking those questions. Because one of the really important things for me in relation to the management of patients is, if you're going to give them advice and if you're going to talk about telling them, we accept that there is a limited availability to treat you, but that this advice should help. A lot of patients, if you can give them in layman's terms, very simple descriptions of why you're asking the questions or why you're recommending the analgesia you're recommending, it will help them to go, you know what, this person I think knows what they're talking about, as opposed to just saying, well, take this. And they say, why? And you go, well, it's good, in terms of an analgesic. And you say, well, no. And I'll talk about analgesics and how we decide upon them later. But I think that's important. Have a bit of a background or a bit of a story to be able to tell them in relation to why you're recommending things to them. For me, avulsion is important. I don't like the complexity of trauma sometimes. I would love if a trauma looks like it does on the screen now, where a patient came in to me and they said, this is what happened to me. And I looked and I went, wow, that's amazing. No other injuries, just an avulsion. Do you have the tooth? Yeah. What have you kept it in? Milk? How long's it been out? A minute. And I would wash it and I would reposition it in really carefully. But it's not like that. Often they will have had multiple injuries and you are trying to prioritize and diagnose and prognosticate all at the same time. So for me, I break it down into two important things. A system whereby I'm saying a main feature, so tooth's out of the socket, a main worry. So my main worry with an avulsion case is replacement resorption. And I think that's important. As someone has just asked in relation to access to the slides as well, this is an on-demand webinar. So as soon as I learn how to do this, which I think I can, this will go back up so that you can access it whenever you want. You will have open access to it. So don't worry about the slides. Yeah, you'll get all the slides and everything. So the main treatment, reimplant it, get it into the mouth. Now, it's funny because this was always the recommendation from the various trauma guidelines. Tell the patient to put it back in, or weirdly tell the patient to put it into their buccal sulcus after rinsing it. And I always just thought, I don't even know if I would want to put my tooth into my own buccal sulcus. So, and the worry is you've got a patient who's upset and distressed and maybe crying, and you're going to tell them to put a tooth into their mouth. And one of the probably catastrophic emergency situations from a trauma would be if the patient were to inhale a piece of tooth. So you can imagine sending them to A&E with the explanation, well, I told them to put it in their mouth and they inhaled it. So, I think that for me, I would ask them to put it back in. It doesn't really matter even if it's the wrong way around, because they're going to be seen on an emergency basis, but it's in the mouth. That's the best place for it, back into the socket. Equally, it will avoid kind of clot formation, and that can happen really, really quickly. Also, in terms of your instruction for the patient, in terms of rinsing their tooth, it totally depends. Someone has asked, how do you tell them to wash it? Because this is totally counterintuitive, because it will say, they'll tell us, don't put it in water, whatever you do, because the PDL cells will be destroyed. But if the tooth has visible debris on it, it would need to be washed on, ideally with saline, but their patients aren't going to have saline. So I would wash it just under some running water as quickly as possible and put it into milk or put it into the mouth. That is completely dependent on what you're trying to do here. It's a compromise between, if you put the tooth back in the mouth with dirt on it, what will happen? And you're going to have potentially infection, you're going to have resorption, so you're going to have a lot of kind of complications associated with the fact that the tooth wasn't cleaned, versus, for example, if you put the tooth back in, having rinsed it underwater, straight back into the mouth, you'll sacrifice some PDL cells, there's no question, but you're not immersing it in water. You're not saying, okay, well, it's staying in there for 45 minutes while I get to the emergency center. So a quick rinse underwater for me should be more than acceptable. One of the other, I suppose, ones that comes up a lot is root fracture. And you can take out the root part, because it's fracture really is the worry. And I think I changed this slide because this was always main feature, displaced coronal fragment, but that happens with a lot of teeth, laterally luxated teeth, dentoalveolar fractures. So any fracture at all, and remember, a lateral luxation involves a fracture of the alveolar plate as well. Think about what you need to do here. You need to reposition. So you need to say to the patient, if they can, so if it is a root fracture, push it back in with their finger. And, you know, historically, then we would say to them, oh, just get to an emergency center as quickly as possible. And of course, if we suspect that there's a fracture there, it will need to be managed. But, you know, a bit of rolled up kitchen paper, kind of folded over neatly. Don't just tell them, don't give them kind of inaccurate advice. Don't say to them, I'll just roll up a bit of toilet paper and put it up against your teeth, because you're panicking and you're not a dentist and you're a patient who you've suffered this injury. You're just going to roll it in a ball and put it into your mouth. Tell them to fold it over into a neat little pile so that they can put it between their teeth. And when they push that tooth in, they can bite on it just to keep it repositioned. So that's what I mean about giving them kind of a basis for it. You know, if someone told me roll up some toilet paper in my mouth, I wouldn't even know. I would probably bite on it on the back teeth. So explain to them what you're doing. Say, you know, the key here is we need to just reposition this and we need to push it back as best you can. In the same way that, you know, if you were stranded on a desert island and you broke your finger or you dislocated your finger, very quickly you would realize that you needed to put it back in. And, you know, of course, they're completely different extremes, but I suppose that's maybe the approach we should be adopting. And remember, the classification of the problem is very, very important, because the priority is bone, followed by dental hard tissues, followed by soft tissues. We all know the dental soft tissues in the mouth, or the soft tissues in the mouth rather, after any dental treatment will heal incredibly well. It staggers me after doing apical surgery that a patient comes back a week later and they haven't suffered too much pain and their tissues are healed. So bone is our priority. And remember, don't think about this in just an immediate sense, because in another 2-3 months when we go back to work, we will have to deal with the delayed complications in relation to a lot of this. And managing the bone is very, very important, because if you lose a tooth or a piece of tooth, it can be managed. But I remember hearing a story before about a dentoalveolar fracture that was managed incorrectly, where there ended up being soft tissue union between the fragments, and the patient ended up with a mobile portion of the maxilla. And that's very difficult to manage without doing it surgically later. And I think that really, really is important. So keep those things in your mind. Keep your 3 S's about spreading infection in your mind. Keep your classification: bone, hard tissue, soft tissue, and use those little things, and maybe write them up on a piece of paper, you know, stick them up on the wall next to the phone. So that, you know, if someone's ringing you, you're going to have something in your mind to say, okay, this is what I need to do. Because sometimes I find, and I've condensed them as best I can, but some of the documents that have been released more recently, they are vast and there's so many arrows. If the patient says this and the patient says this, it's just not practical to go through them while you're speaking on the phone to a patient. And remember, again, guys, it is multiple injuries often in trauma. It's not just a single injury. And we have to be able to try and diagnose those where possible. One word of warning would be to say that these are just guidelines. They are something to fall back on, and they probably are considered best practice, I think, at this stage. But remember that they are guidelines, and sometimes guidelines can be very, very prescriptive, and you guys are going to be doing the assessment of the patient over the phone. You're going to be listening to what they're saying. So, you know, you have to try and figure out, don't immediately say, okay, this is this from Dental Trauma Guide, this is what needs to be done. It is or it isn't urgent. You know, listen to what your patient is telling you as well. Some people with a dentoalveolar fracture will say, my tooth has just moved a little bit. I have a little bit of bleeding. Whereas other people who suffered a concussion injury will be absolutely freaking out and saying that, you know, my tooth's really sore and I'm worried about it. And some of that is down to the patient themselves, and some of that is down to their dental history or trauma history. But it's important to recognize those things as well in relation to what our patient is saying. You can see as well, I've included oral cancer. I haven't included this, as I say, because this is specific to endo. I've included it because the patients will often come to us and they will often say, I've got an ulcer on my gum. And we hear that and we think, whoa, hang on a second. What do you mean an ulcer? Now, remember, you're going to know these patients. Hopefully you'll have access to their documentation, their notes. Medical and social history are really important. We know the risk factors that are there associated with oral cancer. That's not to say it only happens in those patients, but it's an important thing to keep in mind. The site is important as well. Okay, so if a patient is saying, well, it's on my gum next to a tooth that I had a root canal on, again, you're thinking, well, this is probably not something that we need to worry about. You can ask the patient to send you a picture. And again, we know what's important is duration. You know, has this gotten bigger? What does the ulcer feel like? Are there any kind of associated symptoms that might worry you? You know, the patient says, oh, well, I've got numbness in the area as well. Again, that's going to worry you. But if it's been there, you know, for a very long period of time, it could be a draining sinus associated with the tooth. So I think the reason I've put that up is to say that, you know, often it's not, and really is the description from the patient of any value to you in terms of you being able to reassure them and being able to reassure yourself that they don't need onward referral. I think we can see associated with the NHS in particular, that there are going to be difficulties with the management of oncology patients, both currently and longer term going forward, because I think treatment will have to be prioritized and treatment will be stopped, and diagnoses will be missed, because this is one of the hardest areas. So if we are worried about a patient and if we think, hang on, this is something that I think could be sinister, you know what to do in terms of referral, and I will talk about that in more detail later. And I suppose the thing we're going to deal with most often is dental pain. This is a difficult one, because in keeping with the previous slide talking about oral cancer and I suppose the catastrophic outcome of missing it, and of also for the patient in terms of outcome, equally, if a patient is presenting with dental pain, I don't put this up to scare us, because this is very, very rare. But you always need to consider it might not just be a toothache. And if you look, for example, at cardiac pain of orofacial origin, or rather the other way around, orofacial pain of cardiac origin, you know, what are the important things in relation to that? And I think often that pain is bilateral. Okay, and I've read up a lot on this over the last few weeks, because I didn't know that much about it, and I always thought you got a pain in your jaw. And my own dad, I remember he had a cardiac problem, and one of the things he said afterwards was, I had a pain in my lower jaw, and he's got a lower complete denture. And I remember saying to him, why didn't you say that? You don't have teeth. Did you not think that was strange? But that's important. So, you know, equally, if you've got your patient and they've got a set of full fulls and they're saying, yeah, my jaws are sore, look back through their medical history and say, hang on a second, is this something that I might be missing? And also that pain of cardiac origin will radiate elsewhere. You often don't just get a pain in your jaw. You'll probably get it in your shoulder, you know, maybe in your chest, maybe the kind of traditional going down the left arm thing. But keep that in mind. They're rare, but I think it is something that potentially could come up. Dental pain itself, I suppose our two key areas here would be to consider, is it a pulpal problem or is it a periapical problem? I used to always say before that you would fully know when a patient had a pulpal or a periapical problem, because if a patient had a pulpal problem, they would sleep outside the surgery to be first in the morning to make sure when you arrived in. Whereas sometimes people with periapical problems will book an appointment and you'll offer them one and they may say, that's not really convenient. And it gives you a sense that it's not as severe. And I think this paper from Iqbal talks a lot about the different ways in which it presents. And I think you guys will know this, but importantly, is it a sharp or a dull pain? So sharp being related to pulpal, dull pain being related to periapical problem. Is the patient giving a cold response? And you know, it's okay to say to a patient, although I used to always say never use alkyl chloride or ice, and that you had to use blue freeze, but it's not going to be knocking around the general population of Edinburgh too much. So if a patient says, you know, you're worried, get them to put a piece of ice in their tooth while you're talking to them and say, what does it feel like? You know, yeah, it's probably going to be a little bit sensitive, but it might give you an indication in terms of how urgently it needs to be managed. Equally, I might not do it if a patient says to you, the first thing is, I've been awake all night. And also clinically, is the tooth tender to percussion? And should we ask the patients to check that, you know, because, you know, as I said earlier, we don't have the reassurance of a dental exam anymore. Tenderness to percussion is often indicative of a periapical problem. It's not a pulpal problem, certainly not a reversible pulpitis. And I think importantly as well, the stuff that comes out of the papers is that pulpal pain is very, very often, and this is obviously common sense, it's associated with caries. And so, you know, again, ask the patient, what does the tooth look like? You're going to need all of this information in order for you to actually formulate a diagnosis. And in terms of the history, you don't have to ask them that Socrates acronym, because if I was a patient and someone's asked me all those questions, I think I'd get kind of fed up with the situation. And someone was saying to me, you know, oh, what's the site? What's it? You want to know where it is. And as I said before, that might be particularly poorly reported. You do want to know the intensity, but don't say to the patient, how intense is it? How severe is it? give them some kind of scale. It could be a visual analog scale in your mind, so from 0 to 100. Although I have to say, in my experience, people will often over-report their own pain, and that's natural. If it's sore, and bear in mind as well, patients are aware they're not going to be seen by a dentist. I've heard that a lot anecdotally from neighbors and stuff over the last few days. So the word is out there that they're not going to get treatment unless it's very, very severe. So you can see how if that option is removed from you, you might think, oh my God, I better make sure I really get this point across to them. Some people say, you know, if 0 was no pain and 100 was the worst pain you ever experienced, for me, it doesn't really help too much. I think you're putting words in a patient's mouth. I prefer a description of a visual analog scale, 0 to 10, 0 to 100, and ask them about the character. So what does it feel like? You know, can you describe it? But sometimes that open-ended question may not be enough. A lot of patients, for example, when they have persistent discomfort from root-filled teeth, will describe them as sensitive. And as dentists, our reaction is, no, it's not sensitive. And then I say to temperature, no, not to temperature. And I say, well, that's what sensitivity is. And in our mind versus a patient's mind, they're two very different things. So give them a comparison. Look at Iqbal's paper. Okay, is it sharp or is it dull? Is it an ache that you're feeling? Or is it a kind of a sharp, sensitive kind of, you know, a quicker pain? And the short form of the McGill pain questionnaire is really good at that. So again, we've got plenty of time over these next few weeks. Download a copy of it, have it there next to you, so that when you sit down to ring your patient, you say, okay, can you describe it? And I wouldn't go through every descriptor, but I might say to them, you know, how about this or this or this? As opposed to, you know, depending on how the conversation is going, it's going to be stressful for you too. And you might just kind of lose your train of thought, and you may not be in a position then to give them guidance in terms of how to report it. And equally, exacerbating and relieving factors are important. Exacerbating factors more so for me, because I would want to know if the patient says, well, wow, it's intensely sensitive to cold. Although interestingly, I saw the SD-SEP guidance. Some of it says, someone has just asked me to repeat the name of the pain scale. Sorry, that was my Irish accent. It's the McGill, MCGILL, the short form of the McGill pain questionnaire. McGill University is a university in Canada where they do a lot of pain research. But yeah, the exacerbating factors for me, I think, are probably more important. Sometimes relieving factors, if you say to a patient, is anything taking it away? And again, this is one of the nuances of the conversation. Is anything helping? No, I've taken loads of painkillers. And then you say, okay, thanks for that. And in your mind, you're saying, this is the diagnosis. You explain to the patient what's wrong with them. And then you say, so the first thing you're going to do is take painkillers. And they've just told you they're not going to take, or that they've already kind of used X amount of paracetamol. You would be much better off avoiding too much by way of asking that until later, and saying to the patient, giving them the reason for the analgesics. So saying to them, okay, now have you taken pain relief? And they'll say, well, I've taken a whole box of paracetamol. And you say, well, okay, paracetamol may not be working for this reason, so we're going to recommend this with it, and then we will see again in 24, 48, 72 hours how you're doing. So don't let them lead you down a pathway whereby the only thing that is going to help them is treatment, because they may not be in a position to get that dental treatment. And I think that is definitely important. Whether or not analgesics are controlling the pain, you obviously need to explore a few different analgesic regimes, because ultimately, in terms of quality of life or in terms of just sanity, if you cannot control the pain associated with irreversible pulpitis, treatment, albeit an extraction, may be an appropriate option to choose. You do also need to know your diagnoses. That's important. The AAE diagnostic categories are really good. This took me about 10 years to learn. So I would learn, again, you'll find this on Google if you type in AAE diagnostic terminology. But it took me years. When I trained, we didn't use this, and it took me until I think last year to learn it. So I was 10 years out of my postgrad. But it's good because this is what everybody is using now. And in terms of being able to explain to a patient what they've got, in terms of being able to record it in your notes, and in terms of being able to, I suppose, later be able to say, well, look, I've fulfilled all the obligations in terms of indemnity. this is a really great system. It's very simple. It's only one A4 page for every single endodontic diagnostic category. And that's not a lot. So again, 3 S's, 3 D's, 3 A's, a nice simple categorization of diagnoses. And you can see based on those, this is the British Endodontic Society algorithm talking about how to manage it. And you can see what's important down here for me is if you look, we've got a patient who has severe symptoms that is significantly impacting on daily life where analgesics are having no effect. Not some effect, no effect. And that's important because if they're having some effect, remember, an understanding of physiology is very, very important in terms of our management of these patients. Every single person will have an internal opiate system which will start to turn off the pain over a period of time. You are only buying yourself a little bit of time to allow this to subside. No one is saying that advised analgesics or antimicrobials are going to solve these problems indefinitely. It's just allowing us the opportunity to help our patients in terms of the impact on their daily life and in terms of avoiding serious complications. So if a patient is responding to pain relief, reassure them and tell them that, coupled with their internal opiate system, will help them. 42% of pulpitis, according to Michelson, is asymptomatic. It's painless. And that's because the internal system in that patient is switching off that problem. You still have C fibers that are firing. You still have a vascular and a neurological response to a pulpitis, but it's just those patients aren't feeling it as much. So again, have a knowledge of that for the patient. Don't give them these kind of, this routine kind of, it'll take a bit of time to work. Give it 24 hours because they'll be back on the phone to you. And one of the key outcomes when I talked earlier about do telephone consultations work? One of the key outcomes is the patient coming back for reattendance? Now, they were in a medical setting. Are they coming back to the medical practice to be checked out again? And the same with you. If a patient rings you on a Thursday, and what's weird, and the reason I say this is last week, the whole week is just so long and everything is blending into everything else. But you read a lot of stuff online where people are like, whatever you do, kind of pretend that there's a weekend. And I think that's important because if this goes on for a few weeks or maybe longer, if every single one of the days is the same in the week, you get no sense of kind of respite. So treat your weekend as your weekend. Some life advice for the outbreak. But you don't want a patient ringing you back 2 days later when it's on your Saturday and maybe you're sitting there and you're thinking, I'll get a takeaway, I'll have a glass of wine. So you want to make sure that there's not patients calling and calling and calling, and give them the advice, the physiological advice for them to understand why it will take 24 or 48 hours to work. In terms of periapical pain, what is important? I think what's important, as I said, is that how does it compare? It compares in terms of intensity on a lower scale to pulpal pain. And its significance, of course, is from our point of view, can you deal with the impact on quality of life? And I think you can. Advice often may be appropriate here. Advice and some kind of analgesic advice as well. But you also worry, is this something that's going to turn into a spreading infection? You don't worry about that with the pulpitis, really, if our diagnosis is correct, unless you've got a partially necrotic tooth or, there are some clinical situations where it may arise, but it would be rare. A pulpitis is trying to deal with and reassure a patient that this will go away and you will be okay for a few months. But periapical pain, is it periapical pain? And, you don't have a radiograph because, again, to go back to the fact that we're not treating patients or taking radiographs, if you had a patient who said, I have got pain and I had a root filling and I have an ulcer on my gum, and then you brought them in and you looked, you said, this tooth's tender to percussion, soft tissue's tender, buccal sinus, and then you took a radiograph and there was a massive radiolucency extending from a central incisor back to a first molar, we would be extremely worried. And we would say, oh my God, I need to refer this patient somewhere. We won't have that luxury. So you want to try and figure out from that patient, again, back to where's the site of this? What's the size of this? What does it feel like? Don't be afraid to say to a patient, push your tooth with your finger. Can you feel the swelling? Is it soft? Is it hard? Where does it extend to? And if they say, well, it's on the cheek side and all over my palate, again, that's something you want to keep in mind. But in essence, the take-home message from periapical versus pulpal pain would be to consider that the pain experience will be less, but that the risk for complications later might be more. And again, our diagnostic categories are important. Okay, what are normal periapical tissues versus what's a chronic apical abscess? Okay, and really the one that's going to kind of flag up and cause, I suppose, more issues there is your acute apical abscess. So is that something that's just blown up now? And again, that's not a major worry if you aren't getting signs of spreading infection. But equally, you don't want to say to a patient, look, in comparison to the person I talked to earlier who has a pulpitis, you shouldn't be experiencing too much pain. Manage it and say to the patient, you know, take the analgesics. You don't need antibiotics for now. There are no signs of spreading infection, but we'll keep in touch, you know. And then one of the positives I think that's going to come out of this is that there'll be a lot of patients that you review and that you stay in touch with and that you call a few days later, and they will have gotten better. And they will think, wow, this person's great, you know, they didn't even need to see me and they were able to diagnose it. And that, from the point of view of being good for your practice and good for the relationships you build with your patient, that's going to be a great thing, you know, to be able to say to them, I did everything I could for you while I couldn't treat you. And then you will keep those patients and you will bounce back when this is all over, and you will hopefully all be busy and these patients will come back in because you'll have built those relationships even without seeing them. And then if you look again at the algorithm from the British Endodontic Society, again, it's back to, does the patient have severe symptoms that are significantly impacting on their daily life? And that's important because that is individual. That is not, every single patient isn't going to say, yeah, I'm fine with it, it doesn't bother me. A lot of patients will just look for reassurance and will say, no, it's not particularly bothering me. And if you can give them the safety net of saying, well, if it does, and if it turns into something bigger, you can contact me, then that will help them. But some patients, they will feel that it is having a profound effect on their quality of life. So it might be worth delving more into why it's having that effect. Everybody's quality of life has been adversely affected by this. Everybody's. And there may be another layer to it in terms of just anxiety or stress or worry over what's going on, or family members maybe being unwell. And so there may be some kind of counseling or conversation that you need to have with the patient that will help them in that regard as well. Okay. And for an acute apical abscess, one of the things I think that we're not going to be able to do, and where really this is a big safety net that's been removed, we're not going to be able to carry out incision and drainage. And so the incision and drainage as such will be replaced by an antimicrobial. And I will talk about those in more detail later. You don't want to rush to prescribe them, certainly for maybe some of the problems that we have previously prescribed them for. But equally, if you are going to prescribe them, you need to know which one, you need to know how long, how much of it, and you need to understand essentially the medical interactions that there may be in terms of medication that the patient is taking. And I suppose then the last one and the least important one is tooth damage. So what's important? So for me, it's a worry if a piece of tooth is missing, because yeah, a patient may potentially need a chest x-ray, although that would be very rare. I'm talking more about tooth damage. You know, a patient contacts you and says, well, I've broken a filling or I've broken a tooth. Talk to them about their dental history. Have they done it before? If you have their notes, have they heavily restored, well-maintained dentition? Where has this happened? You want to find out, is there a pulpal risk? Talk to them, you know, is it sensitive? If they say, you know, well, I'm not sure, drink some cold water while you're on the phone to me. Put a little ice cube back there, because the pulpal risk is important. And you know, in terms of our ability to manage it, if it's, and in NHS Lothian, if after a trauma, a patient needs a tooth accessed, that at the moment I think is largely being done, because those teeth are easy to manage. The risk of an aerosol generating procedure is often less if you've got an exposed pulp anyway. You might even not generate an aerosol if you didn't use your 3-in-1. We won't have that advantage. So often we will be redirecting patients to use something like this. So go and get a home kit. And this is on a lot of the algorithms and the documentation from a lot of different organizations. I found this on Amazon and I looked at it and I thought, okay, it looks really professional. It looks like something we would have in our own surgeries. And I looked and I said, it's a certified quality product from Germany, and one kit provides enough material for how many teeth? 15 repairs and a universal tooth shade to achieve the desired natural aesthetic result. And I thought to myself, as I said earlier, patients are going to end up buying this stuff and never coming to the dentist again. But on Amazon, on the bottom, it's currently unavailable. And when I went on Boots to try and find one, amazingly on the Boots website, there's a virtual queue. there was a virtual queue, and I would have had to have waited for 52 minutes to just browse through what they have online, and keep that in mind. Because if you've broken your tooth and we're saying, yeah, go and get a dental kit, and they say where, you say Amazon or a pharmacy online, they've got to get online, they've got to order it, they've got to pick the right one, they've got to get it delivered. So maybe familiarize yourself with these and be able to say to a patient, this is what I might potentially recommend. And that is important. And again, it will give them some reassurance in terms of what you're saying to them. The other thing, someone has just mentioned as well, that one of the dentists delivered cortisol to a patient, which is brilliant. Yeah, absolutely great. I think that would be my preference, I think, because it's so easy to adapt. And whether or not patients can buy that online, you can certainly buy an equivalent in Boots, but I couldn't get in yesterday to get the image of it. But yeah, if a piece of temporary material could be delivered to a patient, absolutely, once we're adhering to all this social distancing stuff and you're not obviously coming face to face. But Cavit, yeah, ideal. Cavit or cortisol would be perfect. But yeah, this is how these little fractures are going to be managed, and that will largely be potentially to protect the pulp until such time as you're ready to treat it. Now, if we consider how we're going to manage these emergencies, we are really going to be adopting this 3A's approach as opposed to the 3D's. But link this back to etiology. Okay, 3A's: advice, analgesics, antimicrobials. Ken Hargreaves talked about the 3D's, which were diagnosis, definitive treatment, and drugs. So it's a very, very different approach. And he always lectured, he's an endodontist from San Antonio in Texas. He always lectured really well about that. But that idea of definitive treatment before drugs is not going to be possible in the current situation, at least in the majority of cases. But do bring it back to the etiology and bring it back to the physiology. Listen to the patient. What is it that they're telling you? Is this inflammation? Is this infection? Or is this something that I'm thinking, hang on, this can very, very easily be managed by a patient. So can we get them to put a little bit of cortisol or a little bit of temporary material on it and essentially kick the can down the road until we're ready to treat? So in terms of our advice, you know your patients. I'm not going to talk to you about that today. I'm sure you guys could give me loads of tips and tricks on it, which I'm open to hearing if anybody wants to send them in. But you know your own patients. Okay, so if you've got, and we all have our patients that you think, if you see the name flash up on your phone, and we have people who aren't patients in our lives, and you see a name flash up and you think, oh, bloody hell. But you need to keep that in mind. You may need to, I know a lot of people, and this is anecdotal, and this may or may not suit people, but some people are saying, oh, I wouldn't answer the phone, I would let them leave a message. I mean, it depends on the volume of phone calls you're taking, doesn't it? If you're getting 10 phone calls a day, which I hope we won't be, I wouldn't be not answering the phone, because you're eventually going to have to speak to the person and you may not be able to get back through to them, and that may generate more stress and anxiety for you and the patient than actually just speaking to them. But equally, it might give you a bit of time to process what you're going to say. Where you take the call is important. You don't want to take it, for example, maybe somewhere where it's really windy and you can't hear and they can't hear and you've got your headphones in. So the location of the call, it might be useful to have a little area that you deal with these phone calls on a particular time, on a particular day. You've got your 3Ds, your 3As, you've got your SD-CEP document, you've got a little maybe kind of role play conversation that you speak to them. And all those little things may help you. These are just hints or tips or suggestions. You don't have to do them. You do want to show empathy. Think back to those papers about how patients perceived it and what they thought of these telephone conversations. You know, what was the patient's perception in terms of whether they were getting reassurance, whether they were being listened to, were they being interrupted after 12 seconds? You might want to do it on FaceTime. If a patient has an infection, it might be easier than listening over the phone to them describing the extensions and the site and the size and everything. You may say, well, let me have a look at this, because they may say, oh my God, I've got massive swelling. And then you look and you think, no, that's not huge. And you're not worried. It gives you reassurance, or they send you a picture. And avoid the interruptions, as I say, because remember that the advice that you give them often will be about reassurance. Okay. And remember, particularly in relation to pain, it is a biopsychosocial model of pain, which means that, yeah, there's a biological aspect to it. So what is it? Is it an irreversible pulpitis? Are the C fibers being fired off? There's a psychological component to it. So this terrible term of psychogenic pain, thankfully, has largely been removed. But of course, there's a psychological element to it. If patients suffer from neuropathic pain, or if a patient who has a phantom limb pain is told, but you couldn't have the pain, could you, because you got no arm? That's not true. That's not true, both biologically and psychologically. Understanding the psychological component of it is important. And that's then slightly different to the social aspect of it. So how is it impacting on quality of life? All these terms that we used very flippantly down through the years, we're now really going to become focused in on. So how is it affecting their quality of life? They may say to you, for example, to give a specific indication, they may say, well, I woke up 7 times last night. And, or someone may say, no, didn't wake me last night. That's a tiny example. So how is it affecting your quality of life? Previously, people would say, you know, oh, well, I don't go out, or you know, and largely we're very limited in terms of doing that now anyway, but, you know, ask them those questions, okay? Because I think that's important, and understand, I think understand that the patient is going to be feeling all of these things. It's not just the toothache. There are other impacts of it as well. And it is about reassurance and understanding. You just want to say to them, listen, I know this is an awkward situation. I do understand what you're going through, and give them that kind of reassurance that you are listening to them. In terms of analgesics, this is a really good resource. You'll get all of these online. And this is the Oxford League Table of Analgesic Efficacy. It's from 2007, but it's still, I mean, it's still largely applicable. A lot of the medications that score highly up on this scale are COX-2 inhibitors, which wouldn't be routinely recommended anyway. And they had some issues with cardiovascular incidents after them. But I think this tells us that ibuprofen is the best. And I'm going to talk about that specifically in a second. But again, this will give a patient, if a patient says to you, I've done that and it's not working, to be able to say to them, look, there's a league table. There is a league table about this, and this may help you. Okay? So use that. And don't just say to them, yeah, paracetamol will work. It's on the NHS website. You know, of course it is, but they can see that. But patients aren't checking the Oxford League Table of Analgesic Efficacy. So that's important. Now, in terms of the options we're giving patients, this is hot off the press because I got this. This is from the BES website. And this is largely, I think, what is being recommended within NHS Lothian. I'll go forward a slide first before I come back, because there were big worries in terms of the use of ibuprofen in the presence of coronavirus, because there were anecdotal reports coming out of France initially that patients, and in particular young patients, were having negative outcomes in terms of the virus in using ibuprofen. And this was a previous issue with the previous SARS illness a few years back as well. And so the guidance was there's no strong evidence to suggest that it can make it worse, but that you shouldn't, if you are known to have COVID-19, you shouldn't be taking ibuprofen. So it's this cohort of patients who are known coronavirus 19 positive, they shouldn't be told to take ibuprofen. But patients who are asymptomatic, and this is a very important part of your phone conversation and your phone consultation with your patient, because it was a very important part of our examination of the patient before this all kind of kicked off a few weeks ago. You need to find out systemically how they're feeling, because having the virus or not having it is important in terms of, number one, your management in terms of advice and analgesics, and number two, very important in terms of where that patient goes to for their treatment within NHS Lothian. So patients who are known to be asymptomatic, you can, for example, recommend ibuprofen, and that can be recommended in its usual form, 400 milligram or 600 milligram, depending on mild, moderate. Sometimes it can be included with paracetamol. We know that there is a synergistic effect of having paracetamol and ibuprofen together. Very, very important, okay? And again, explain that to the patient. Don't just say, yeah, just take them together. Tell them why they're taking them together, and warn them to not exceed the maximum dose. And talk to them about dosage. Give them practical hints. Talk to them about the effects that ibuprofen will have potentially on the stomach. Know their medical history. Rule out giving it in peptic ulcer patients or maybe even asthmatic patients. If pain is severe or moving kind of into moderate to severe, you can sometimes recommend diclofenac, which can be taken 150 milligrams in a day essentially. But if a patient has got a history of GIT problems, they're potentially going to need to supplement that with omeprazole. So you'll need to know that within your prescription. So look at this new SDCEP document. It's really good in terms of its description of that. There's no question ibuprofen is far more effective than paracetamol. If you feel that you've got a patient who has got a pulpitis, who has been found to have COVID-19, there is some talk, and if you look at the Oxford League table, they will talk about the use of an opioid analgesic. They're not particularly great for moderate to severe dental pain, but they can be used. And again, it's another string to your bow. It minimizes your anxiety and your stress because you're able to say to the patient, okay, this isn't the end of the road. We have got another option that we can consider. In the States, they're quite common, although they quite critically attribute some of the issues they're having with addiction to the overuse of opioid analgesics, whereas they're not overly commonly used here, certainly within dentistry. But again, take a look at the BNF, the NICE website, and that will give you some guidance on it. You can see it's up on the screen here. And then to know, as I say, that there is potentially a link between COVID-19 and negative outcomes if you use ibuprofen. In terms of antibacterials, sorry, someone's just popped up a question. If the pain doesn't resolve, that the centers will consider seeing the patients. I would totally agree with that. Totally agree with that. I think that if you look at all the algorithms that have been mentioned in relation to this, if it's severely affecting quality of life, and if after 48 to 72 hours, the pain doesn't resolve, then yeah, I would be considering onward referral. Because the simple fact of the matter, and it's a good question, the simple fact of the person never put their name up, but you get the credit anyway, you know who you are. And the fact of the matter is, in the vast, vast majority of patients, even those with an irreversible pulpitis, analgesics coupled with internal opiate system of the patient over a time period of about 2 or 3 days, the vast majority of them will improve. They will improve. So I think that's really, really important. If they're not improving after that period of time, it may be worth onward referral and possible treatment, because one of the things when we came up with the system in terms of which patients and how you would manage patients within NHS Lothian, but I was talking to people all around the UK in hospitals, irreversible pulpitis is actually one of the easier ones to solve. And if we go back to the very beginning and we think about aerosol generating procedures, and we talk about whether or not they're appropriate or whether we should be justifying them now, the paper that came out of Wuhan in relation to management of emergency patients talked about the fact that you would put rubber dam on, you would disinfect the patient's mouth first with a peroxide mouth rinse, rubber dam goes on, you'd put it over the patient's nose, access into a tube once you've administered local should be incredibly quick. And even if you're not, the patient isn't fully anesthetized because your local is only effective in about 50% of patients with an irreversible pulpitis in a mandibular molar, you can access in there very quickly, get an intrapulpal in, or even just get some leather mix or a dentopaste over the top. So in a weird way, one of the things that's really going to help us is if this truly is an irreversible pulpitis that cannot be managed with the analgesics, the reassurance, and the 72-hour time period, actually those ones are probably easier to treat if they do end up in one of the green centres in NHS Lothian. So the short answer to your question, I've gone on a lot about that instead of giving a direct answer, is yeah, if it's not working, the patient should probably be referred onwards. In terms of antimicrobial prescription, when do we do it? So when there's evidence of spreading infection, when there's systemic involvement, and when the immediate draining of the infection can't be achieved, which it can't be. And one other thing, just in relation to referral of patients on for pain, patients cannot self-refer themselves. Yeah, definitely not. There's going to be a telephone number on one of the algorithms at the end. It is for dentists only. I wouldn't hand it out to patients at all. The patients won't be accepted for treatment if they self-refer, and that will do two things. It will annoy the patient enormously, and it will also probably annoy the public dental service dentists who are working. I know just from personal experience in Edinburgh, it will be in Chalmers. So just be careful with that. That really, really is important, guys, because I think over these next few weeks, we're going to rely on them quite a lot. So definitely no self-referral for the patient. If a patient is really, really worried about spreading infection or something that they think is a true emergency, of course you would ring NHS 24 and they would talk to someone there who would then appropriately refer them onwards. But if we're talking specifically about endodontic complaints, like for example, an irreversible pulpitis and associated pain, then no, I wouldn't get them to refer directly themselves. So in terms of antimicrobials, we all know this. There's no point in me going on about this for too long. But you've got your amoxicillin as your first line, medical history permitting, and metronidazole as a first line as well. Maybe both of those supplemented together. And you've also got your second line antibiotics, as you can see up here on the screen. So again, a knowledge of those, go to the British Endodontic Society algorithm or the SDSEP, and you will find all of this. And it's all pretty self-explanatory. I think this is a great paper. It's done by Douglas Robertson, who's a consultant in Glasgow, but it's a paper done for doctors. And I love the way that they've approached it. And they talk as well about antibiotics only being prescribed in signs of systemic spread. Evidence is currently insufficient to talk about one regime over another. But you want to include amoxicillin as your first choice, and then clindamycin for your second choice. In terms of dosages, I probably would agree, depending on the degree of the infection and certainly in the climate that we're in now, I wouldn't object to kind of double doses. So maybe a 400 milligrams of metronidazole, John, being offered for signs of infection, because again, our main outcome measure here is we want to actually get this to work, and we don't want the patient coming back to us or having to go onwards. So yeah, maybe a 400 milligram of metronidazole might be appropriate. Antibiotics for pulpal problems, I would rule out. They're not going to help. Particularly, I remember arguing one time for a very long time with someone I worked with who was an endodontist, a really good endodontist in Australia, and he said that if you have a micro abscess in the coronal portion of the pulp, why wouldn't antibiotics work? And I still don't know the answer to that question, but all the reviews would suggest that they don't need them, and I don't think they're going to help. You might get some kind of placebo effect, but I would be saving the antibiotics for the infective problems. I'm not pushing you one way or the other. You may find some patients will need to be managed with them. The evidence doesn't support it, but if you look at these Cochrane reviews, if you look down the bottom, it will say it confirms the necessity for further large sample and methodologically sound trials that can provide additional evidence. So as always, with any systematic reviews, there's no conclusion other than to say we have no evidence, but the evidence we do have, although it's full of bias, is not helpful. In a practical sense, patients may ask you this. They may ask you about, I don't want to get antibiotic resistance. Do I need to finish the course? And there have been loads of studies done on this. The short answer to that for me is they should finish the course, but that the course should be an appropriate length. It doesn't have to be 7 days. And actually, if you look at a lot of the SDSEP stuff, it will say antibiotics for 5 days. So don't set to the default, well, I'll give it to them for 7 days. And equally, people ask about, will I end up with resistance to the antibiotic, or will it be effective over that time period? A lot of that is to do with what you're picking the antibiotic for, and it's more relevant to medicine, I think, than dentistry, because our first lines are going to be amoxicillin and metronidazole, and they work because they're broad spectrum in the vast majority of cases. And we know the bacteria we're dealing with in endodontic infection, and we know that they work well. So I would be administering those. I wouldn't go too off script unless there was a very specific medical reason for it, but reassure your patient. Tell them that we're giving you a short course for 5 days. Do finish it, because they may say to you, I've always gotten 7 days, but they don't need that, and tell them that the dose you're giving them and the antibiotic you're giving them is effective because it attacks the bacteria that cause the infection that they've got, and also because the amount of it you're giving to them is the appropriate amount. So again, don't just say to them, look, that's just what we give. Give them the background to it and answer those concerns for them. In terms of the actual prescription process itself, it has become, I suppose, slightly more complicated. You write it on a normal prescription pad, which I'm sure you have. You do it in a dark pen, we've been told, because this will need to be scanned. You then scan or photograph the prescription. You can take a picture on your phone or whatever. You then identify the closest pharmacy for your patient. You can find that on NHS Inform. You'll be able to type it in and put in the postcode, and it will identify where the pharmacy is. You will then need to email that prescription from an NHS email, from a secure email, to them with the patient name and an urgent prescription written on the top, even if it's not urgent prescription. Just put that in. I think that's important. You tell the patient, obviously. For me, that's probably the part that's like when anytime I've done any kind of an indirect restoration, I forget to take the shade or make a denture, and tell the patient. You could set up this whole system and be like, here you go. You forget to collect it. You allow an hour because they've actually get, and then you send a hard copy as well. That's important. This is a private patient would be less common because a lot of these medicines are going to be funded on the health service, and so the private prescription, or there's a specific reason for that, I would contact the pharmacy directly. But this is the system, and this is what needs to be adhered to. Also, if you're advising analgesics and antimicrobials, put them on the same prescription. You don't want to double it up. It doubles up all the work. So if for some reason you are recommending something outside of the ordinary in terms of analgesics, if you're saying to them, I want you to get, diclofenac, or if you want them to get something that isn't over the counter for whatever reason, put it on the same prescription, okay? In terms of the referral pathways, this is important as well, so that you're familiar with them, have a knowledge of them, look at a few of those algorithms. I would look at SDCEP, British Endo, and NHS Lothian, I think, or whichever NHS trust you're in, or wherever you are in the country. Obviously this is online. So have a knowledge of the pathway that's available. You don't want to say to the patient, I'm going to send you here, but I'll have to double check that. That would kind of freak me out if I was a patient. And be familiar with them. And your familiarity will grow as the situation develops and as time goes on, hopefully not for too long. And make contact with them as well if you need to. Okay, if you've got any concerns, obviously I have an NHS, or it's mainly a university role, but an NHS role. And if you guys need anything, I'm happy for you to contact. You can send me an email, no patient identifiable data, my NHS email. You can send NHS stuff to that, robert.philpott@nhslothian.scot.nhs.uk. So we've all got remote access. So anything we can do to help in this situation, because it's hard for everyone, just let me know. You can drop me an email. And then this is our algorithm from NHS Lothian. You will find this online, but you can see the number in this algorithm is not to be given out to patients. It's not to be given out to patients. This is for referring dentist use only. And that's really, really, really important. The system will fail if it's administered out to too many patients. So that is really, really important. Final thing, I suppose, is to consider about our indemnity. And a lot of you will have heard from MDDUS over the last few days. And they did a few good things, and I think a lot of companies have done this, but they reduced down the indemnity down to one session to allow us to be able to deal with patients over the phone and give them advice and do remote working. That's important. I would maintain that. Equally, the GDC have given some guidance in terms of remote working, remote consultations, and remote prescribing. And that, I think, is important as well, to have a knowledge of that. Because ultimately they're the regulatory body, and their description on that, it's actually not bad, to be fair. I know there have been tons of documents that have come out of Wimpole Street, but this one is pretty short and it is only 2 A4s. So again, in the first instance for these next few weeks, I might have a couple of copies of that available just so you can have a look at it and familiarize yourself with it. All of this is going to only take up maybe 10 or 12 A4s. And as I say, we have plenty of time to look through them, but indemnity is important. So make sure, for example, that you are maintaining confidentiality. Confirm that it is the person that you're talking to. You're not going to talk to someone, oh, look, my husband has hurt his tooth or whatever. So make sure you confirm that with them. Establish the needs of the patient and get them to understand what it is you're doing. It's not treatment, okay? You're triaging here, essentially. You're doing a remote consultation. Keep records, that's really, really important, and have that GDC guidance there, which is all self-explanatory, common sense stuff, but have that stuff there for yourself as well, okay? So in terms of a conclusion, number one, listen to what the patient is telling you. Listen in terms of their medical history. Listen in terms of their description of the problem. Listen in terms of what you're listening to yourself. You know what I mean? So intuitively, and ask yourself why you're reaching that conclusion, because your gut instinct on it is probably the correct thing. So keep that intuition about you and keep understanding that you're going through different processes and systems in your mind, and stick to your principles when you do that. This is the same patient, it's the same you, it's just a different situation. Stick to an understanding of biologically why it's going on, physiologically why it's going on, and what are the complications that the patient might suffer. And then using those approaches, follow the pathways afterwards. Okay, so look at the SD-SEP guidance. Is it routine? Is it advice only? Is it urgent? So is it escalated up a level, or is it a really true emergency? Is this something that needs to be managed straight away? And know the pathways that are available. You're going to be the first point of contact, but the patient's then got different types of processes that, and areas that they can go to. Are they a green centre? Are they a red centre within NHS Lothian? Or is it a situation whereby they've got to contact NHS 24, you know, and it's something extremely urgent, okay? So that's it for today. I'm happy to take any suggestions. I'll get Magda to obviously send out CPD certs and various things afterwards. That may take a little bit of time for us just to sort out, because you've got to go through the registration and everything. In terms of my own contact details, my NHS Lothian email is robert.philpott at nhslothian.scot.nhs.uk. So any NHS things that you're worried about, or if you need some advice, you know, if it helps ease the burden on my colleagues in the public dental service, I'm happy to help. The practice email, you guys will have the tele-dentist email is there as well, just in case there's something you want to ask about. I hope that a lot of you come back and we can join in again next Tuesday. Please let me know if you are happy with the Tuesday, if you want more sessions, because I have plenty of time on my hands, so I can arrange more of these if we need to. And we can just talk through this. Hopefully we can utilize this time. And you saw, I was trying to think of a not cliched kind of, you know, encouraging way to send out the email, but just to say, you know, we can use this time productively. It's not ideal. We'd all rather be in practice, but why not just use it, update our CPD, and then we're ready to go afterwards. And it means that we don't have to be taking time off work to go to lectures and stuff when all this is over. Okay, so thanks very much for joining, guys. I will hopefully talk to you all again next Tuesday at 12 o'clock, and let me know if there's anything else you wanna chat about. Okay, take care, guys.